Welcome to the PCLP Colloquium on Assessing and Enhancing Provider Knowledge and Attitudes. My name is Dana Marshall, and I'm an Associate Professor of Pathology, Anatomy, and Cell Biology at Meharry Medical College in Nashville, Tennessee. I do research on oral cancer, and I've been a PCLP mentor for all 3 years of the program. The Affordable Care Act has made it possible for 32 million people who were previously under or uninsured to obtain health insurance. Many of these underserved individuals will make a community health center their medical home. These people will represent many of the nation's most vulnerable, including those who have been caught in the cycle of poverty for way too long, as well as many newcomers to this country. They will represent a cross-section of humanity, reflecting every race and ethnicity, young and old, people of different nationalities with different cultures and different religious practices, and it will include people who don't fit into the societal norms in regards to gender and sexual orientation. Although diversification of the medical workforce can help greatly in assuring medical care that reflects the diversity of the community health center consumers, it is not enough. One only needs to do a quick search of the literature to see the growth in information regarding provider knowledge and attitudes over the last 30 years. The reality is that the medical community itself realizes the need for continual assessment of its own knowledge and attitudes. The future is in good hands. The young people who are presenting their work in this colloquium have touched on all aspects of future needs for efficient and effective health care. They understand that they, as providers, will drive the development of the exceptional health care for those in need, and they will do this by continuing to grow in their own knowledge and awareness of the needs of their communities. Based on what you hear today, I think you will agree that the future of primary care and community health centers is very, very bright, and you will enjoy hearing from some of those future providers today.
My name is Jennifer Eccles. I'm a third-year physician assistant student at Mississippi College. I was placed at Jackson Hines Comprehensive Health Center in Jackson, Mississippi. My project is motivational interviewing, incorporation of a patient-centered model approach in community health centers to facilitate better patient adherence and outcomes. Motivational interviewing, which I'll refer to as MI, is an empirically based patient-centered approach that when applied to everyday provider-patient exchanges elicits better communication, resulting in improved patient satisfaction, adherence, and outcomes. MI has been empirically tested extensively with repeated demonstration of efficacy. Despite its clinical success, however, there is little research of MI being utilized in CHCs. The study was designed to include 10 clinicians and 50 to 100 patients who were seeing their clinician for any reason. Clinicians received a pre- and post-test following an introductory course in MI. They also answered a brief survey, which was a 5-point Likert scale, to assess their willingness to apply MI in the clinic and to receive additional training in the future. Following their visit, patients were given a satisfaction survey, also a 5-point Likert scale, with questions specifically directed at MI concepts. A descriptive and graphical analysis of collected data was conducted and further correlated with the Mann-Whitney-U test to see if there was any difference between the Likert median score of male and female responders. There were 3 hypotheses tested. I will go through each hypothesis and whether each one was supported or rejected. Hypothesis 1. A majority of clinicians introduced to MI will develop positive outlooks on the method and would be interested in obtaining additional training in the future. The MI provider training survey indicated that 100% of respondents expressed desire to have additional training in MI and that they would use the concepts of MI in their practice. Hypothesis 2. Patients counseled and treated by clinicians trained in MI will have greater rates of satisfaction as compared to those that were treated by clinicians not trained in MI. Percentages and mean were calculated for individual responses, which indicated higher rates of satisfaction when treated by providers who had undergone MI training. Hypothesis 3. There will be no significant differences appreciated in the responses of male versus female respondents. The Mann-Whitney-U test was used to compare the Likert median score between male and female patients. Using these calculations, the hypothesis was rejected, and it should be assumed that there are some levels of variation between male and female responses. In closing, MI would be an excellent communication method to incorporate into CHCs to elucidate better adherence and overall patient outcomes based on the preliminary findings of this pilot study. Further investigation is warranted in the future to assess the long-term benefits to the CHC patients with more extensive provider training.
The title of my project this summer was The Assessment of Providers' Nutrition Education Counseling in the Refugee Community. It was conducted through the Rochester General Medical Group, and it was conducted by myself, Gianna Ramos, and I am a second-year medical student at Howard University College of Medicine. The objective of my research was to assess the diverse techniques used by providers and also to explore any strategies to promote healthier nutritional habits among refugee communities. I was able to attend the 4th Annual North American Refugee Health Conference, and it was during this time that I surveyed 31 providers about how they conduct delivery of nutrition counseling in refugee communities. I also asked about the barriers that they face and potential strategies to improve nutrition counseling in refugee communities. Our key findings was that most providers use verbal interpretation services to work with refugee communities in delivering nutrition counseling. One of the major barriers faced by the providers that limited their nutrition counseling in the refugee community was lack of time. For strategies to improve nutrition counseling, most providers suggested that having printed materials in patients' native language and will help with nutrition counseling, and the providers were also willing to participate in a 1 to 2 day nutrition seminar to better their nutrition counseling strategies. Recommendations for the future was to have separate intervention programs, such as a community workshop referred to by providers, and also to eliminate time and interpretation barriers. Home demonstration videos could be created by the refugee communities themselves, and providers can provide visual aids to be taken home by patients as well as another strategy to improve nutrition counseling. In addition, it was suggested that these providers could solicit collaboration among local college and medical school students to make DVDs about nutrition education counseling in the refugee community. So basically, all these strategies put together can make for a better and effective way to assist refugee communities with improvements in nutrition counseling. Thank you.
My name is Erica Johnson, and I am entering my second year at the University of Alabama in Birmingham. I did my project on an improvement to cervical cancer screening at the Legacy Community Clinic Montrose location. Legacy has recently become a patient-centered medical home, and they are trying to improve preventative care at the clinic. One of their focuses is to improve cancer screening. I decided to observe Legacy cervical cancer screening since it is the easiest gynecologic cancer to prevent, and the pap smear exam can be performed by a primary care provider during the patient's appointment. I observed how many women ages 21 to 65 visited the clinic between April 14th and June 16th. Then I determined how many of those women received pap smears during that time, and of the women who had abnormal results from their pap smear, I observed their follow-up care. I used the Centricity electronic medical record system to get the information that I need. Specifically, I used the patient-centered medical home and compliance report. In the results, I found that only 67% of the females who visited the clinic during that time had pap smears. According to CDC Healthy People 2020, the percentage should be 93%. Only 3 physicians actually had 93% or greater. In addition, only 4 people out of 20 had the appropriate follow-up care after their abnormal pap smear. Therefore, I created a comprehensive approach to improve the cervical cancer screening by introducing interventions before, during, and after the clinic visit. Some included having the call center schedule pap smears when the patient calls in or when they call to remind patients of their appointment. When the patient arrives for their H&P appointment, the provider should go ahead and give pap smears. Also, flyers and information needs to be placed inside exam rooms on the walls to remind both the provider and the patient of cervical cancer screening. In addition, after the visit, the referral committee needs to follow up on the results from the dysplasia clinic until they are recorded to the patient's chart.
My name is Ken Kitayama, and I'm a rising second-year medical student at the David Geffen School of Medicine at UCLA. And this summer, I was placed at Altamed's Health Services Corporation in Los Angeles, California. And the title of my independent service learning project is Provider Perspectives on a Bilingual Online Patient Portal in a Predominantly Spanish-Speaking Safety Net Population. The objective of my study was to explore providers' perspectives on the implementation of a bilingual patient portal in a Spanish-speaking safety net population and to contrast providers' attitudes regarding patient portal against those of patients. In conjunction with the implementation of an online patient portal in June 2014, full-time primary care providers completed a 33-item multiple-choice survey, and primary care patients completed a 37 multiple-choice survey. Surveys were administered during June and July 2014 at 12 of the 43 primary care clinics affiliated with Altamed Health Services, a large multi-site community health center with locations in Los Angeles and Orange County. Patients were eligible if they were 18 years of age or older and were fluent in English or Spanish. The majority of providers, or 85%, were concerned about having to carve out time to reply to patient portal messages, and most providers were concerned about reimbursement issues, about 64%. Although 73% of providers recognized that the patient portal would improve patient satisfaction, only 39% reported being likely or very likely to recommend the patient portal to their patients. In terms of recommendations, I would recommend that Altamed Health Services inform providers of the many benefits associated with patient portal use, such as improved patient satisfaction, increased productivity, better clinical outcomes, etc. Altamed should also reassure providers that patient portal use helps to increase clinic efficiency by having providers play less telephone tag and allowing for asynchronous communication that allows providers to answer messages at their own convenience. Altamed should also share patients' generally positive perspectives regarding My Altamed, the online patient portal, with providers and encourage providers to promote patient portal adoption. And finally, Altamed should also allow for protective administrative time to allow providers to respond to patient messages in a timely manner. Thank you.
Hello, my name is Dana Osbern, and I will be an incoming second-year student at Midwestern University, Arizona College of Osteopathic Medicine. My project is entitled Informed Consent, Policy, Procedure, and Staff Education. My placement for the Primary Care Leadership Program was at Adelante Healthcare in Phoenix, Arizona. The Quality Improvement Department at Adelante was looking to revise their current informed consent policy and also needed to find legal and appropriate clinical references to support their policy. Additionally, they were curious to see how well versed their clinical team was regarding the policy. To assist them, I created a survey of 6 items to send out to providers and administrators, testing them on the informed consent process. One item asked providers to name 3 procedures that require informed consent. One asked providers to describe how long they take to educate their patients about a procedure, and how they ensure the patient understands the procedure. Another item asked providers who was required to sign the informed consent form. I received 23 out of 53 surveys back, a 43% response rate. All of the providers correctly named 3 procedures requiring informed consent. The most popular answers were incision and drainage, removal of ingrown toenails, and biopsies. 26% of the respondents correctly stated that the patient or legal guardian, provider, and a witness are all required to sign the informed consent form. An additional 22% at least named the patient and provider as required to sign the form. The average time providers take educating patients about a proposed procedure was 6.36 minutes, and 78% of the providers use a teach-back method to ensure patients understand the procedure. The last question on the survey was open for providers to write about any comments or concerns they had regarding the informed consent process. Based on the answers listed, I made an educational poster listing all the procedures requiring written informed consent on one side and all the procedures requiring verbal consent on the opposite side. This document was completed and sent out to all providers to be used as a quick reference guide as needed. The quality department received the responses to the survey and plan to use these to train the staff on the informed consent process. They are also interested in using the survey again as a post-test to assess staff retention of the training. In addition to the survey, I also found a variety of legal and clinical references to guide the quality department. I listed all the references along with suggested corrections to the policy and sent it to the quality department for review.
Hi there, my name is Gabby Polly, and I was placed at the Anthony Jordan Health Center in Rochester, New York. The project I decided to develop was based from an interest in how do you manage chronic diseases. Chronic illnesses are pretty much everywhere in the United States, with almost half of the adult population suffering from either diabetes, hypertension, cardiovascular disease, high cholesterol, etc. And it can be quite a challenge for the family practice, which is traditionally based on an acute care model, to redesign itself and say, okay, how do we manage these illnesses that are really affected by a patient's day-to-day behavior more than they are by any medication or treatment we can provide in a short-term basis. So self-management, for those of you who don't know, it's basically just giving, rather than traditional patient education where you teach patients about their condition, teach them about outcomes. This is where you're teaching techniques, giving patients the tools they need in order to manage their own conditions. And there are many different models of self-management. There's motivational interviewing, there is the ask, tell, ask technique, there's a teach back method, there are several. And for people in primary care, you always get training in one or two, but then there generally is not a lot of follow-up or continuity within a certain practice of, okay, how do we really deliver this type of care, and is it really built into our practice model? And so what I wanted to do was assess within family medicine. I wanted to ask all providers, physician, nurses, physician assistants, nurse practitioners, what familiarity they had with different self-management models, how confident, if they had been trained in a certain model, how confident they felt utilizing that model, and in what percentage of appropriate patient visits did they actually utilize that model fully. And so I used a web-based survey and found that 100% of doctors and nurse practitioners and physician assistants surveyed had been trained in some kind of self-management, while only 40% of the nursing staff, meaning the RNs and the LPNs, had been trained. I also found that on average, all types of providers felt only somewhat confident utilizing a certain method. And I also found that on average only 45% of patient visits were self-management techniques used. So my recommendations are for the Jordan Health leadership to allocate resources for training and developing infrastructure, as well as establishing reimbursement for self-management education, and ultimately that will improve the management of chronic conditions.
I'm Gianna Ramos, and my project is called Hearing from the Youth, a study of the needs of adolescent patients at Matthew Walker Comprehensive Health Center. The first aim of the project was to survey adolescent patients that are seen at Matthew Walker to give them an opportunity to share their health perceptions and needs. The second aim was to use that data collected from the survey to create a provider manual to allow providers to best serve their adolescent patients' needs. I chose adolescent patients for a couple of reasons. The first reason is that adolescents are more likely to engage in risky behaviors, and as a result, it's extremely important that they have accurate health education. The second reason is that it's during adolescence in which patients begin forming opinions not only about their providers, but also about the healthcare system as a whole. And then lastly, I feel that adolescent patients are often caught between adult care and pediatric care in the sense that they're not quite adult patients, but they're not quite pediatric patients as well. I created a survey, and that survey was administered in English and in Spanish, and was anonymous to encourage participant honesty. The first portion of the survey was multiple choice, and the second portion of the survey was Likert scale questions about patient-provider interaction. There was an open-ended question at the end of the survey to encourage patients to give feedback or any information that was not asked about in the survey questions. 26 surveys were completed, and overall patients reported positive interactions with their healthcare providers. 77% of patients reported being honest all of the time with their providers, even about difficult topics such as sexual health and drug and alcohol use. One question of the survey asked about what types of health education patients received, and 42% of patients reported receiving nutrition counseling, as well as 23% reported receiving sexual health education. However, patients were also asked what type of health information and education they wanted, and they reported that they wanted information not only about nutrition and sexual health, but also about body image, college, drugs and alcohol, stress management, and depression. They also reported that talking face-to-face was the most helpful way to educate them, and that their parents were who they received health information from when they weren't at the doctor's office. The survey findings were helpful in determining that adolescent patients generally feel comfortable at Matthew Walker, and knowing what kind of health education patients want and the best mode of delivery will be useful for providers' future interactions with their patients. All of that data was used to create the resource manual for providers, and the resource manual included a discussion of the results, all of the health education topics, as well as my recommendations. My recommendations for Matthew Walker include a future study on retention rates of patients, because many of the adolescent patients did not show up to their appointments, as well as culturally sensitive preventive care because of the number of adolescent patients with extensive family histories and ethnic predisposition to certain diseases. I also recommend that patients receive all of the healthcare information they reported that they want, as well as education of their parents, because they report that their parents are who they get healthcare information from.